After all these literature search and all that thing, there is a pro-con is to be published, still to be published in Red Journal. Now they have said that both perfusion techniques are equally effective. Like both the techniques are beneficial in aortic surgery. There is no significance of bilateral ACP or unilateral ACP. And they said that unilateral ACP or RCP both are equally effective. So again, that depends on the institutional practice or the surgical practice, which technique to use for. But nowadays, the trend is towards the antegrade cerebral perfusion. Another important method is the neurophysiological monitoring. And there is a review article published in Red Journal in 2013. Now, the basic concept of this, the normal blood flow of the brain is around 50 mL per minute per 100 grams. The importance of neurological monitoring is abnormal EEG occurs when the flow rate is less than 22 mL per kg per minute. This is the ischemic threshold. And EEG is the most sensitive monitor to detect the cortical ischemia. And EEG is usually absent when the flow is less than 15, and the infarction occurs when the flow rate is consistently less than 17 mL per kg per ml per minute per 100 grams for next 3 to 4 hours. So that is the basic concept of neurophysiological monitoring. Now you can see the EEG is the most sensitive monitor. It can detect the ischemia within 20 to 30 seconds. So this is the monitor which is most commonly used, but nowadays the common monitor used is the NIRS. This is a ischemia monitor, EEG. It can detect the synaptic activities of the cortex, sensitive to ischemia. The advantage is that it is well maintained with anesthetic. There is no disadvantage of anesthetics on EEG monitoring. Then if the silent EEG is there, that means adequate cooling is there. It is very good monitor for deep hypothermic circulatory arrest, and we can have slow frequencies and loss of amplitude whenever the temperature is decreased, or if there is any evidence of ischemia is there. Then somatosensory evoked potential is not very commonly used for brain protection, but it is most commonly used for spinal cord protections like cortical, like spinal cord evoked potential and motor evoked potential. But important monitor which is used commonly is the NIRS. It is a continuous measurement of the regional oxygen saturation in the bilateral frontal lobes. And this is the monitor we use. And these are the electrodes which are placed on the frontal lobe on the forehead of the patient, and useful tool for effectiveness of the cerebral oxygen during antegrade perfusion or retrograde perfusion. This is the way we put the electrodes on the patient on the forehead, and this is the way we monitor the 55 and 59 are the values in the left and right hemisphere, like frontal. And the principle is the emission. There is emission of the near infrared wavelength generated by the light emitting diodes, which are absorbed by the red color hemoglobin from the erythrocytes. And the value of saturation less than 50% is synonymous with the poor neurological outcome. Whenever the value is consistently less than 50%, we should always suspect there may be some temporary or permanent neurological deficit in the post-operative period. And we should do immediately some intervention to increase the value, either by doing the bilateral antegrade perfusion, and we can convert the unilateral to bilateral. And this is the way, this is the circulatory, the initial period. The perfusion pressure is around 68. This is the deep hypothermic circulatory arrest. At this time, the values are around 60s. And whenever the pressure, the circulatory arrest is done, the temperature is around 26, moderate hypothermia. The value is around 40, 45, 46 is likely. There's slight decrease in the regional oxygen saturation is there. If it is less than 40, then we change over to the bilateral antegrade perfusion. Now, it is again, I have said that it's a good monitor whether we have to convert the patient from unilateral to bilateral perfusion. There is a paper published in 2009, in 2010 in the European Journal of Cardiothoracic Surgery. Then again, it is a good monitor to decrease the perioperative neurological complications. Mechanical ventilation, it can decrease the incidence. ICU, that is the overall picture, use of physiological monitoring in aortic surgery. Other methods are like topical cooling. Basically, the basic concept of using ice packs on the head is it is an adjuvant to the deep hypothermic circulatory arrest. It prevents the passive rewarming of the brain, which occurs during the circulatory arrest. So basically, just as adjuvant, but the role is still not defined. We can put the ice packs during the cooling period, and we can remove it during the rewarming period. Then pharmacological agents decreases the CMRO2, metabolic demand, energy demands of the patient, so, like barbiturates, nowadays not commonly used, NMD antagonists like magnesium or ketamine, still they are in experiment, nobody is using those. Only drug which is most commonly used, which we are also using, is the corticosteroid, which is helpful in decreasing the inflammatory response during the bypass period, but the hyperglycemia is associated with it. We have to control the blood sugar levels associated with the corticosteroids. Lidocaine again decrease the sodium influx in the ischemic neurons, but still the role is debatable. Role of ABG, like the blood gas measurement, that is also important. Again, there is a dispute today whether we should use PS-stat or alpha-stat. PS-stat proponents say that it causes vasodilatation, so there is adequate cooling is there, there is homogeneous cooling is there of the patient, but the alpha-stat people say that it maintains the autoregulation, so cerebral protection is better. But what we are using PS-stat during the hypothermia phase, and whenever the rewarming is done, we switch over to, we are not adding carbon dioxide, we are switch over to alpha-stat. And the blood sugar we maintain around less than one, we try to maintain is less than 150 milligram per cent. This is our experience, like we have done around 700 cases in last 7 years, and we have used around cerebral protection techniques in 330 patients out of about 45% of patients. We have a mortality of around 2 patients, we have mortality, and neurological dysfunction permanent is not there in not even a single patient. We have used cerebral protection. Only 4 patients have temporary neurological deficit that has recovered before patient gets discharged from the hospital. This is a case we did last month. He's a 53-year-old, ascending aortic and distal thoracic aorta dilatation. We did ascending aortic and arch replacement with elephant trunk. Hypothermic circulatory arrest was done for 45 minutes at 25 degrees centigrade. We used SACP, antegrade perfusion, and IRS was used, and second stage was done after 2 weeks. That is continuation of the elephant trunk. The patient is okay. He was extubated on the first post-operative day. There is no neurological deficit. Another patient we did is 72-year-old. He was post-CABG, 4 months old. 4 months back, CABG was done. He developed pseudoaneurysm of the ascending aorta. Exofemoral bypass was established, and circulatory arrest was done for 20 minutes at 18 degrees. We used NIRS, and aorta was repaired. He's again extubated. We used the same methods. There is no neurological deficit. So this is our protocol. We use bilateral radial arterial lines for perfusion pressure monitoring. We use nasopharyngeal and rectal temperature. We use right axillary artery approach for infracalcular incision. Yeah, just last slide. And the core temperature we maintain around 22 to 26 to 27. The flow rate is this, and the perfusion pressure is around 40 to 70 millimeters of mercury. And this is our post-operative protocols. We maintain, we do CT scan for all the patients on first operative POD. Electively, we do CT scan for all the patients bedside, and apart from all the monitors. And lastly, the guidelines in 2010, they stated that brain protection strategies to prevent the stroke, and it is a class 1 recommendation to use the brain protection strategies in these patients. And class 2A recommendation is deep hypothermic circulatory arrest, selective antegrade perfusion, and retrograde antegrade perfusion are the techniques which are used alone or in combination in these surgeries. And institutional experience is an important factor. With the techniques which you are comfortable with should be used in these surgeries. And the hyperthermia should not be used. It is rather injurious to the brain. It should not be used as a class 3 recommendation. Thank you.